All right, so we're doing shock and infectious disease. So shock, we'll talk about. All right, it's usually low blood pressure. You can assume they're probably in shock, but as we'll find out, there's a lot of compensation that happens before they actually drop their blood pressure, and we want to be alert to those signs. And there will be a little bit of infectious disease, right? So kind of our focus will be the antibiotics. So you can recognize if your patient needs antibiotics still or should get antibiotics, and what the antibiotics kind of mean, right? And it kind of plays into all your microbiology knowledge, right? And where what bugs are which, and which antibiotics will cover which, right? Antibiotics are very much like chemotherapy, right? So certain chemos for certain cancers, certain antibiotics are for certain bugs. So and certain bugs make you have a pneumonia, certain bugs make you have a UTI, right? Certain bugs make you have abdominal infection, and when you are immunocompromised, there are other things can happen, all right? So we'll talk about that when we get to antibiotics. But shock, all right? So we are in shock, not the shock you hear in Hollywood. It's like, oh, they're in shock, right? That's what happened. No, shock is very well defined, right? Sometimes there's what's called undifferentiated shock, meaning that we don't know what it is, right? We don't know if it's septic, we don't know if it's cardiogenic, we don't know if it's obstructive, we don't know if it's neurogenic, anaphylactic, we don't know, right? So those are the complicated ones, but today we're going to give you a clear outline of which of the ones that are well defined, right? Such as hypovolemic shock, right? Hypovolemic shock you can think of as your tank is empty, or in your car, right? The tank is empty in the human, so they don't have enough fluid circulating around. That fluid can be either blood, right? So it can be blood, or it can be actual fluid, right? Someone that's dehydrated, right? They're vomiting, or they have diarrhea, or they are heat exposed, right? Or they have DKA or HHS. These are all things where they're losing volume, right? They're losing not blood, right? It'd be really weird if a DKA patient started losing blood in front of you, right? They have polyuria and they are peeing out too much fluid, right? And the polyuria could be our fault. We're giving too many diuretics, right? So pay attention to the eyes and nose, and the hospital can help. And then we have cardiogenic shock, right? Our pump is broken, so our pump being our heart. So we are unable to pump the blood that we have, right? So we have blood, we have volume, but we cannot pump it forward. So it backs up, right? Backs up in the lungs, and we get what symptoms? You get some CHF symptoms such as pulmonary edema, right? You get the pink frothy sputum or the increase in fluid in the lungs. You can use ultrasound and see B lines. You can use an X-ray and see pulmonary vascular congestion, right? You can do POCUS ultrasound and look and see that they have a dilated ventricle that's really not really working good and is dilated out, and you can see some wall motion abnormalities. That's a fancy word for saying the wall is not working good, right? Because they probably have an MI, right? So. And of course, you can look at ejection fraction roughly with that as well, because if your ejection fraction is poor, you probably are not putting a lot of blood out as you could, right? That's your test score for your heart. And then we have obstructive shock, and obstructive shock kind of overlaps with cardiogenic. Sometimes you'll see some things, hey, I thought it was cardiogenic, but it's fine, right? Sometimes they do overlap. Basically, either there's a problem with the heart or the problem with there's interference for the heart, right? So there's a pulmonary embolism in the way. So the heart can't pump blood out, right? Which ventricle is that? Can't pump blood out because there's something in the pulmonary arteries. Is it the left heart or the right heart? Right heart, right? So right heart is when you have a PE. This case right here, we have an obstructive shock in the aorta, right? That might be like a aortic stenosis, for instance, a really, really severe aortic stenosis, or they might have an aortic dissection, which is dissecting apart and it's obstructing the forward flow of blood. Or we have like a tamponade, for instance, right? We have a tamponade that's squishing the heart, and it can't pump blood forward, the right ventricle or the left ventricle, okay? And the last one is our pipes. Our pipes are leaky, so our pipes are not returning fluid back to the right heart, right? So usually blood goes out, and then it should come right back to the heart, right? And if we vasodilate all those vessels, not a lot of fluids can come back to the heart, right? So that's a pipes are leaky situation. As we'll find out, when you do have what's called septic shock, which is a type of distributive shock, then your pipes are 95% leaky, right? So giving 3 liters, 4 liters, 5 liters is not going to do a lot, right? 95% of it's going to leak out into the periphery and actually worsen outcomes. So we give them 2 liters, 3 liters, but then after that, really, we got to switch over to vasopressors. And vasopressors, we'll kind of be touching base on a few of them today, but then with our next lectures, we really talk about IV titrations and all the different receptor sites they work on, beta 1, beta 2, alpha 1, etc. Okay, all right, so now you're in shock. All right, so shock, yes, low blood pressure pretty much means you're in shock, but usually you have hypoperfusion to your organs, and there's signs ahead of time that you might have be in a shock state, right? And it's because your tissues have an inadequate blood supply. And that inadequate blood supply could be due to low oxygen state, or it could be due to a low flow state, which is usually what we're thinking about with our different shocks, right? So we have a low flow state to our tissues, and that's a low oxygen delivery to our tissues, and they're going to start freaking out. And what are they going to start doing? They're going to start making lactate, right? Lactic acidosis will occur because they're hypoxic. Well, their PO2 is 400, but the cardiac output is like 1.5, right? So that's not, yes, there's different components to what delivers blood or oxygen to our tissues, which we talked about, and respiratory, and we'll bring back some of those infographics. Okay, so you get this acidosis, and this lactic acidosis is like kind of like a debt, right? Hopefully it's like when you open up a credit card because you're not really making as much money as you want to, and you get a little, I'm going to pay it back, I promise. The debt's not going to get too bad, and it's called a lactic acid debt or an O2 debt that your body goes into, and then when O2 returns, like it's going to cash in that lactate, and the lactate is actually valuable for it, right? Lactate is actually a stimulant for the heart to increase its as a fuel source. Right, so for when it's under stress, so it can be good, but when it gets higher and higher and higher, like over 4, then it starts causing problems. Right now, it starts causing the acidosis part. Right, it was always an acid all along, but the lactic acidosis can, when it gets higher and higher, 4, 6, 8, 12. We saw 28 the other day. Right, so those are really, really high lactic acids. Right, an acid is an acid is an acid. So we know that when that happens, the pHs go which way, down or up? To start going down, and we know that every enzyme and every protein, every process in the body requires a good pH and a good temp, right? So they start denaturing at that point, and then your active myosin bridges can't work, so therefore you do what? You start vasodilating, and the heart's not going to work good either, but are we going to start vasodilating? If you're vasodilating, that's going to lower my blood pressure in a state where I already have low perfusion in my tissues, right? So is that going to help or hinder the process? It's going to definitely hinder the process. It's going to make it a further inadequate perfusion and further lactic acidosis. So we've got to stop it at some point. We've got to stop the production of lactic acid by providing, maybe it's oxygen, or usually providing perfusion. If it's hypovolemia, we fix the volemia, right? If it's cardiogenic, we fix the cardio. If it's septic, we fix the sepsis, right? So those are usually our top 3. Okay, if it's untreated though, more organs are going to start to fail, and you're going to start to get what's called multi-organ dysfunction syndrome or multi-organ failure. You'll sometimes see it abbreviated as. And multiple organs can shut down. The lungs can shut down, right? The liver can shut down, and the kidneys can shut down. Whenever you intubate somebody that has has a lung process, that's already like a 20-30% mortality, right? Only 7 to 8 patients, and every 10 patients that you intubate, only 7 or 8 will actually make it out of the ICU, right? So when you add on someone that also has acute kidney injury, that bumps it up by about 35%, right? On top of that, so that's already like a 55-60% mortality. And then you have now you have liver failure or heart failure. On top of that, that's going to start causing more and more dysfunction and more mortality. And then you talk, the brain is a system as well. So they have confusion and they're intubated. Whoa, you're already 40-50% mortality. So you can see this little guy right here, or this should be a little higher, but you can see with 4 organs down, right? It's already like 100% mortality, right? So that means they are confused, intubated, and renal failure, right? And then now they start developing some cardiogenic components. You see the troponins start rising. That's or EKG changes. The mortality is extremely high. So we have to recognize that when we see all these things happening. Sometimes you'll ask a provider, can we get another vasopressor? Can we do this and this? And they realize that it's the futility is very, very high when you have especially like an older person or a person with a lot of comorbidities, with already like EF of 20% when they came in here, or they already came in with end-stage renal disease. Those things kind of push them higher and higher up the mortality chain. Okay, so you can see here the common denominator for all these different shocks is unfortunately a death state where we want to try to avoid them. If they're on the empty tank train line to death, they want to fill the tank on the way. What kind of shock was that? That was hypovolemic shock, right? So you want to try to do all the interventions we can before they get to that point. Same thing if they are on septic shock, right? Their pipes are dilated and leaky, right? They could be dilated because of neurogenic reasons, right? They don't have the SNS to squeeze down on the vasculature, and all we need to do is provide some squeeze for them, and hopefully we can turn them around and they can come back to their normal state, right? Same thing if you have leaky pipes, like in a septic shock, right? Or we have like pipes that are clogged, like in a PE. We can try to fix that. We could give a thrombolytic to bust the clot so we can get good forward flow, right? So that'd be an obstructive shock, right? So, shock is reversible as long as we don't get too far down to getting more and more organs compromised, right? So that's why we keep track of kidney function, keep track of lung function. How do you know someone's lung function is good?
The vent settings.
You can look at the vent settings. The vent settings are 35% PPO5, not as bad as someone that's 100% PPO12, right? Also, we can use the fancy PF ratio, right? It's PaO2 divided by their FiO2. So the PaO2 is, let's say 50, right? And they're 100% oxygen, that's 1, right? 50 divided by 1, that's a PF ratio of 50. That's not good, right? Usually they define lung failure as less than 200 or less than 250, right? So we have cardiogenic shock. That's where our pump's not working. We got hypovolemic, they got dehydration, or they have blood loss. So we'll touch base on a few trauma things. We don't do trauma here, but we have to recognize that we do have, GI bleeds sometimes they're bleeding out, or post-surgical patients that are bleeding out that we have to recognize. You got septic shock. That's number one. It's like 64% of ICU patient or of shocks are septic shock. So it's more than a coin flip where you get someone in sepsis, right? And then we have anaphylactic shock. I've seen that maybe like once or twice a year at the most, right? They're very, very rare to get an anaphylactic shock. Usually gets turned around before they get to the shock state. And then we have neurogenic shock. You'll see that like in spine patients. You'll see that in patients that are going towards brain death with herniation. You'll see them going to a neurogenic shock. And then what shock are we missing here? What's the shock that is not mentioned yet here that we've been talking about? They all lead to systemic hypoperfusion, but we're missing. Distributive is a kind of umbrella term for let's put it in a different color here. Distributive shock is your neurogenic shock, your anaphylactic shock, your septic shock. So all these guys down here are your distributive shocks. Okay, which one's missing? Neurogenic's there. Neurogenic, obstructive shock, very good. So obstructive shock is missing. So that's where, again, sometimes cardiogenic, they kind of overlap. Like these two technically are obstructive. When you have a PE or tamponade, those are obstructive shocks. So it just depends on your source, but we kind of define them as different things, right? We're not going to give inotropic support to support the heart function when someone has a PE. That doesn't make sense. That's why we separate it out in two different types of shocks. There's a little overlap though, because sometimes those can put you in failure, but the failure isn't the heart's fault. The failure was the heart failed, but the failure is the PE or the aortic dissection or the aortic stenosis or the tamponade, right? Or tension pneumothorax, for instance, that's pushing on the heart, and the heart can't outflow the blood. No blood means tissue hypoxia, lactic acidosis, and we got to stop that before it gets worse. Right. On the next slide, we'll divide what the difference is between septic shock and cardiogenic shock. Those are two big ones we're touching on today, besides hypovolemic shock. But the difference between those two really is, are they alert or not? Usually someone who's septic is very, very toxic in appearance. They have a fever, they're very, very confused. And whereas a cardiogenic shock patient is usually mentating to the very, very last moment until they give out, right? Until they can't compensate anymore. All right, so the goal always to figure out the cause of the shock, right? Why is my patient in shock? Are they hypovolemic? Are they have a cardiogenic component? Do they have a septic component, right? And we know when someone has sepsis, we have to call a code sepsis and identify them as septic and then give them antibiotics as soon as possible. We know that if we give antibiotics early, it's better than giving it late, right? It's like the 1 hour, 3 hour bundle. right? Hypotension, yes, is a defining characteristic, but there is compensation that will occur with hypovolemia, for instance, right? They'll be losing volume after surgery, and then eventually their blood pressure will start tanking as well, right? Same thing with septic shock. Septic shock they can be in the first stage of septic shock where they're compensating, right? When you have sepsis and all these inflammatory mediators are flying around, they can actually make your heart hyperdynamic. It's going to have an increased cardiac output, right? And with cardiogenic shock, for instance, they could be compensating for a while, right? The SVR or the SNS can be raising the vascular resistance, raising it. That's not going to help the heart, but it's going to raise your blood pressure, maintain your blood pressure. And as you squeeze down all that vasculature, what other symptoms might you get? So you take away blood flow from other places. Get some diaphoresis, yeah. What else? You get some cold skin, right? And since the heart is now working hard against this increase in afterload, it's not going to be able to pump the blood forward as well as it could before, right? And it's going to start backing that blood back into the pulmonary vasculature, right? So it doesn't go forward anymore, right? Can't go forward, so it starts backing all the stuff up into the lungs, right? And you get pulmonary congestion. So they say someone who's cold and wet has a much, much higher mortality and also much, much sicker patient when they are cold and wet, not diaphoretic wet, but lungs wet, right? And like last time we talked about the PA catheter, if you have a PA catheter sitting inside the pulmonary arteries, you expect that number to be high or low? Be high, right? Because all that fluid is not going forward, it's backing up to the lungs and it's filling those vessels with more and more pressure and more volume, and your pulmonary capillary wedge pressure will go up, right? Greater than 18 really tells you that you are going to have a cardiogenic situation on your hands, right? There are other reasons for elevated PCWP or PAOP or wedge, whatever you want to call it, right? If you are extremely volume overload, yes, that could cause it as well. But you have someone that's volume overload, are they going to be like cool extremities? Probably not. They're probably going to have good perfusion, and they might have some edema as well. But yes, your cardiogenic patient could have edema too. All right. So a cold and wet person is not as great as a patient that is dry in dry lungs and warm extremities, right? So warm and dry is kind of where our goal is, right? We'll try to diurese these people. We'll try to increase inotropy so there's more forward flow. And that's kind of how we fix cardiogenic shock. And we have a whole section dedicated to cardiogenic shock, right? But early septic and cardiogenic shock, they can have a patient that is with a good blood pressure, right, with a decent blood pressure. Sometimes something to consider is like their history of hypertension. All right, if you have a history of hypertension, you usually don't sit around 110 systolic, right? You see that someone's on 4 medications, you haven't given the 4 medications all day, and they're 110 systolic. It's like, what's going on? Why are they have something else brewing, right? They have it's almost a hypotension equivalent, right? If you have a hypertensive patient that's sitting in the low 100s, that's probably a patient that is like early septic shock, right? So septic shock and cardiogenic shock, and comparing them, right? So we have septic shock is someone who is very, very toxic in appearance, right? They have a fever. It's the only shock that has a fever. But neurogenic shock has warm extremities, not hot extremities, right? They're not going to have a temperature of 103 or 101, a neurogenic shock patient. Yeah, their extremities will be warm. They're not going to be cold like someone with cardiogenic shock or late septic shock. But who has warm extremities, septic shock and neurogenic shock, who has a fever, it's the septic shock patient, right? Because that's the inflammatory process, right? Whether it's from a surge response or from an infectious etiology, these things are going to cause a amount of fever. And of course, if you're older or immunocompromised, you might even get a fever, right? So we have that little caveat we think about with we talk about sepsis and surge criteria, where they have a temperature or they don't, or they have a low temperature. Both of those things can indicate a source of infection or a source of inflammation, right? So you got a fever, you got someone that's toxic appearance. They look really sick, right? They look like a train wreck. So, oh boy, why aren't they intubated, right? So that's someone that is usually a septic shock patient. Compared to a heart failure patient looks fine. They're talking to you, they're watching TV the whole time. They look absolutely fine, but they're on like 2 pressors. It's like, that's actually before they get hypotensive. But they look absolutely fine. And the blood pressure is maintaining until it's not, until the blood pressure starts getting lower and lower and lower. And then we have to add medications to support the blood pressure, right? They may continue mentating just to the last moment, and that's when they start getting confused all of a sudden, right? And then pulse pressure. We talked about pulse pressure last week with A lines, right? You expect the pulse pressure of someone with sepsis to be how? What does a septic shock patient look like with a, when we talk about pulse pressure? And what is pulse pressure? The space between, right? That's a song, right? So how do you measure that space? It's between the systolic blood pressure and the diastolic blood pressure. We don't divide it, we just subtract it, right? So 120/80 is a pulse pressure of 40, right? And if someone is in distributive septic shock, what is being affected? The systolic or the diastolic? Diastolic, right? So yeah, diastolic is being affected, right? So you're vasodilating with septic shock. All these inflammatory mediators are causing the widespread vasodilation, right? And now that it was 120, let's say it's 110, but now the diastolic has plummeted, right? So it plummets, so that's going to widen my pulse pressure with someone with septic shock compared to a cardiogenic shock, right? Cardiogenic shock, you can't push a lot of blood flow forward, right? So systolic, diastolic, right? So you can't push blood forward, so that's a low systolic, right? And then the SNS is like, what the heck? My baroreceptor is not being tickled. What's going on, right? So that's going to increase afterload. It's going to vasoconstrict, right? So the diastolic blood pressure will go up. That's going to make that number narrow, right? So just looking at the blood pressure on the monitor, right, you can see if it's wide or narrow. That can tell you if someone has sepsis or cardiogenic shock. Okay, urine output will be low in every shock. That's not really a defining characteristic. And oftentimes, you have to wait an hour before you can measure. It's like, I know that they are, tachycardic and the pulse pressure is very wide and the blood pressure is low, but I'm going to wait an hour and get the urine output. We're going to see if it's low or not, right? So urine output is something to consider. And of course, we can look at labs to see if the kidneys are being affected. But really, what you're looking at, again, blood pressure and temperature can clue you in. Right, so our distributive shocks, these guys are the ones that are, you have anaphylaxis, you have neurogenic shock, and the most popular one, septic shock, right? So those are the ones you're going to be thinking about when your blood pressure is low and your pulse pressure is what? Wide or narrow? Wide. When you have wide pulse pressure, you have a distributive shock, right? You're vasodilating for some reason. Right, so we got to figure out what it is. And if they have like a fever in front of you, you're probably thinking septic shock. And if you're going to Vegas, you have a 64% chance of getting it right that it's septic shock in the first place, right? If someone has a shock state, right? So our goal with these guys, you're going to start compensating. Our goal, again, is a goal for every diagnosis or problem is to treat the underlying problem, right? So if they have a neurogenic problem, we're going to try to fix that neurogenic situation. Why do they have a lack of SNS activity? Well, maybe they have a spinal cord lesion or they have a brain herniation that maybe we could try to intervene upon. Okay, and then extremities cool, right? So you have cool extremities. Yes, late sepsis will cause this, but you're going to have someone that's usually cardiogenic, right? Another situation might be someone that is hypovolemic, right? They lost a lot of volume. They're compensating some more. They have a little bit of SNS activity, a lot of SNS activity, and a lot of SNS activity. They're really clamping down to try to circulate what volume they have, right? Because their tank is empty. So you can look at your CVP, can eyeball it. Usually, again, we mentioned before in our last lecture that high CVP you can take home, but for low CVP, there could be other reasons why your CVP is low. Okay, so you have cardiogenic shock or a obstructive shock is when you aren't able to push the blood forward. So all backs up into the lungs and then backs up into the right heart. And the right heart, we can measure those pressures on a triple lumen catheter or a PA catheter, and we can see if the CVP is high or not, right? And then there's other things we can do. If we have a catheter in place, we can see what the wedge pressure is. We can see if that's the left heart is failing. We can look at the PA pressures to see if the PA pressures are really high. We can see if the right ventricle is failing versus the left ventricle. All right, so then hypovolemic shock, again, we're going to restoring as much blood volume as possible if it's blood that's being lost. If it's just volume that's being lost, like in DKA or HHS, vomiting, diarrhea, then we're going to start to replace that as much as we can, right? So are they drinking alcohol? Are they bleeding? Because alcohol, H. pylori, puts you at risk for what? Ulcers, right? And the alcohol itself puts you at risk for cirrhosis, right? When we talk about our GI section, it'd be very obvious that these are causing a GI bleed on our hands, right? So getting the history and what's going on can help determine kind of what shock we're dealing with, all right? And the compensation was just like any compensation. The SNS compensates for low oxygen states, for low glucose states, and for low pH states and high CO2 states and low. But also, primarily, what we're talking about here is a low blood pressure state. When you have a low blood pressure or low flow to the baroreceptors in the aorta, then you're going to start squeezing down your vessels because the SNS got involved, right? And yeah, these are delineated in the different shocks, but there you can have two shocks at once, right? You can have someone in septic shock because of their pneumonia, let's say, and they have a history of CHF, the EF of 10%. All right, so now that's complicating it, right? And you can say they're on steroids because they have lupus. Well, now you have put 3 shocks in play. So there's all kinds of things that can happen. And then they develop a stroke and herniation, and now you have 4 shocks in your hand. All right, obviously that's going to be a much higher mortality, but all these things can be interlaced. Okay, so what are the causes of shocks, right? So what are the causes of hypovolemic shock, right? You have inadequate circulating volume, so that means what's empty? The tank's empty, right? So this can be either hypovolemia or hemorrhage. That's very, very cut and dry. It's probably the easiest shock to understand. I have hypovolemic shock, I got hypovolemia, right? I got low volume circulating, right? And it's one of 2 reasons. Either you are hemorrhaging it out into the street or you are vomiting into the toilet, right? These are the reasons why you would have a hypovolemic shock. So we have a whole section on hypovolemic shock that we'll touch base on. But as you can see, or not, so you can see that you have, we lost picture here. All right, so hypovolemic hemorrhagic shock, again, those fall under or the reasons for them. They're both hypovolemic shock. Sometimes you'll hear people say hemorrhagic shock. It's like, was that hypovolemic or distributive? Which one is that? Those are all hypovolemic shock, either due to hemorrhage or due to hypovolemia, right? Why would you lose volume? You've got a burn patient. You have someone with GI issues, vomiting, diarrhea. If they have GI issues like GI bleeding issues, now we're into hemorrhagic shock, right? Dehydration could cause significant hypovolemia, excessive diuresis, post-obstructive polyuria. That means when they fixed their AKI, right, their acute kidney injury, they are recovering from their kidney injury, and you can have what's called post-obstructive diuresis, where they pee a whole bunch of fluid because they have a lot of catching up to do with all the volume they're unable to deposit before. Now that's where you get a lot of extra diuresis. So it's important to pay attention to make sure they're not getting too hypovolemic, right? In hemorrhagic shock, we have retroperitoneal hemorrhages, intraperitoneal hemothoraxes, OBs. OBs, that's where they're counting pads, and they give you an exact amount about how much blood is coming out. That's where you get your stage 1, stage 2, stage 3, stage 4 shock. Otherwise, it's really kind of an estimate, kind of where they're at. Okay, and then obstructive shocks. So obstructive shocks is inability for the LV to empty or the RV to empty, right? Why can't my heart unload itself? The heart is functioning just fine. Well, technically, but it's not able to pump the blood forward, right? It could be due to a tamponade, a cardiac tamponade, or I have a tension pneumothorax. All this air is going in, but it can't go out, and it's compressing the heart, and the heart can't pump the blood forward anymore. So obviously, we're going to start compensating first until it gets to what's called a tension pneumothorax, and it's tension pneumothorax when you have a low blood pressure associated with it, right? And that'd be called a what kind of shock? A obstructive shock, right? And then abdominal compartment syndrome. So we'll talk about this more in GI, right? But when you give too many fluids to a patient, all those fluids have to go somewhere, right? We know that 95% of the fluids leak, right? When you have a sepsis process, so all those fluids usually go into the belly, and all those fluids in the belly can actually compress the kidneys and cause kidney failure. So we want to make sure that we are alert to patients that have this increase in abdominal pressure, and that can actually decrease the ability for the heart to even pump blood forward, because all this blood is all this fluid is back in the lungs, or in the lungs, below the lungs, right there below the diaphragm in the belly, and now all that pressure can back up, and your heart can't unload effectively. And then auto PEEP. So we talked about auto PEEP briefly in pulmonary, right? So you're putting all kinds of PEEP inside, all kinds of volume inside, and you should be able to exhale it completely, right? What if you don't exhale it completely? Now you have air trapped inside, and you're going to add on the next volume on top of that, to the next PEEP on top of that. It's going to keep getting bigger and bigger and bigger until it's going to compress the heart, and it can't pump blood forward anymore. And then cardiogenic shock, right? So we have LV failure. So our left ventricle can't pump blood forward anymore, right? Well, it's not because of an obstruction like in cardiac tamponade. It's because the heart itself is weak, right? It's unable to pump the blood forward effectively, right? It can if it wanted to, but it can't because they have some kind of underlying MI, or they have a CHF that's got to the point where their EF's really, really poor, right? These are things where they have like an LV failure, right? That's our heart failure with a reduced ejection fraction, or HFrEF, right? So in this case, we're going to have all this extra preload because we can't get rid of it, right? We can't pump out the blood that the heart's been delivered. So the preload goes up and up and up, especially in the left atrium, right? And we can measure that with our PA catheter. And what is that value again? That's the wedge pressure, right? The wedge pressure assesses the left atrium. And if my left ventricle can't pump the blood forward, it's going to start backing up into the left atrium and eventually into the lungs. And in the lungs, we get our pulmonary edema. Okay, so we got systolic failure, valve failure. Sometimes aortic valve stenosis can be up top, and obstructive shock, a really, really severe aortic stenosis. Then the heart's working fine. It's just the aortic stenosis is getting in the way, right? But otherwise, our valves can, fail on us if we have an MI or we have CHF, and now that's going to put more stress on the heart, and it's going to start, getting more dilated until the ejection fraction is more less effective and less effective, right? And then what else? So we got LV outflow obstruction. So you can develop really, really profound hypertrophy. That's where your diastolic failure or your HFpEF, your heart failure with a preserved ejection fraction, can get to the point where it starts occluding the outflow of blood, right? I want to say obstructing because that's why there's overlap between the two. And then RV failure. So we spent a moment talking about RV failure in MIs, right? So you have an MI to your which vessel? Which vessel is occluded, would cause a right ventricular failure? The RCA, right? So your right coronary artery could be failing, and that can cause a RVMI, right? The right ventricle fails. And your CVP goes up because CVP is a measurement of what chamber of the heart? Right atrium, right? So the right atrium that's where your triple lumen catheter sits, and that's where your PA catheter has an output to. And that value can go up and up and up and up, and that can tell your RV is failing. How do you know it's the RV, not the LV? Well, we can measure the left atrium, right? Compare the wedge. If that wedge is fine, but the CVP is high, that tells me that the right ventricle is under duress, right? Or under stress. It could be due to an RVMI, or it could be due to a pulmonary embolism that might be in the way. It could be due to pulmonary hypertension that they already have brewing before they came to us. And that can eventually lead to RV failure. And RV failure is very, very high mortality, and it's very risky situation that we have some medications we can do, and it's getting a lot more understanding over the last 10 years or so. All right, and arrhythmogenic. So we have an arrhythmia situation that's causing me to fail to pump blood forward. Right? Why is this happening? Well, if I have a bradycardia, I fill the blood perfectly fine. I can fill up with 100 cc, 150 cc's even. I have a great preload, but I have a bradycardia. I can only put out about 30 beats per minute, right? So 30 beats, that's a lot less cardiac output than if I had 60 beats, right? So that's a low cardiac output with bradycardia, because cardiac output is what formula again? Is your stroke volume times your heart rate, right? So that's my cardiac output. If my heart rate is really, really low, I'm not going to get a lot of good output, right? I'm going to get a poor cardiac output. And then tachycardia. So you have a heart rate is too fast. You don't have a lot of filling of the heart, right? Instead of 150 cc's, it's like 30 cc's. And yes, the heart rate's great, right? But the stroke volume, how much I'm going to be able to put out with each stroke of the heart, is going to be poor. Okay? So this is our example of cardiac tamponade causing what kind of shock? Not distributive, right? The pericardium is getting under pressure, it's building up, and then there's increased pressure, decreased flow back to the heart because it can't fill, right? There's blood can't be delivered to the right atrium in the first place. So not only can we not push blood out of the heart, but we also are not getting blood being delivered to the heart because we have all this squeeze around it, right? And that's going to cause a decrease in cardiac output. Obviously, we're not going to have a great stroke volume, right? And that's going to lead to an obstructive shock. And when you have a cardiac tamponade, you can notice it on, obviously, an echo. You're going to be able to see all kinds of fluid sitting around the heart here, right? All that extra fluid sitting around. That's something they could just do, real quick with an echo or with a point of care ultrasound, the POCUS, and they can look to see that they have all this fluid around the heart, and that could explain why they might have a low blood pressure, right? Because low blood pressure, and what other two signs tell you have a cardiac tamponade? It's called Beck's triad, right? So you got a low blood pressure, and we got distended neck veins, a rise in our jugular venous distension, or which hemodynamic would rise? CVP would rise. And if you have a PA catheter in place, what else would you see on your PA catheter? You have equalizing pressures. So your PA pressure is 25 over 25. What the heck? I thought it was 25 over a dime, all right, 25 over 10. But the pressures go up and up and up because you're putting a catheter right there in the chest. Obviously, it's going to increase the pressure on everything. So your CVP is 25, my PA pressure is 25 over 25, my wedge is 25. What the heck's going on, right? Those are equalizing pressures, and that's a sign of tamponade. Also, you can see how it's like kind of a fun time going back and forth through the heart, through the in the chest wall, right? We have EKG leads attached to our chest. Those aren't moving, right? But the heart is moving. It's dancing, right? It's like footloosing in there. So it's going to be, you're going to be seeing this pulsus alternans. So you can see how these complexes are higher and these complexes are lower, right? So whenever you see that beat to beat variability, that's a high suspicion that you might have a tamponade situation. If they're all low, it could be an obesity situation, right? There's not a lot of impulses being thrown, or someone that has very, very low ejection fraction will be why all your EKG complexes are very, very low amplitude, right? But if they go from low amplitude to high amplitude to low amplitude to high amplitude, it's not because they're like moving around in bed all the time, right? It's because their heart is moving within the chamber, within the pericardium that's full of all this fluid, right? So that usually takes a while for this to develop, right? They have a pericarditis, they have an infectious process or the cancerous process that causes pericardial effusion. Again, like I mentioned, if I put 5 cc's into your 20 cc's of blood that's circulating around your heart right now, you would immediately go into tamponade. Whereas someone that's, has chronic development of this fluid over each day, right, they can have up to 1 liter of fluid in that pericardium that we need to get out, right? And how do you get it out? Pericardiocentesis, right? And then pulmonary embolism. So that causes a obstructive shock to which ventricle? The right ventricle. And it can lead to RV failure as well, right? It could be such a catastrophic increase in pressure for the right ventricle, it could just straight up fail. First, it gets under what's called strain, RV strain, and then it goes to RV failure, right? But the other piece on this is that yes, they're going to increase the afterload, but what we can do is we can, fix that by, yes, you can dilate the dilate the pulmonary arteries. That way it'll make it easier on the afterload that the pressure has to overcome. But also we can give thrombolytics, right, to bust up that clot in the first place. And why does it put so much strain on the right ventricle, right? It goes from pressure of like 25 to 45. It's like big deal. 45, the left heart hits up to 120s, 140s, 160s all the time. But the right ventricle is not used to that. It's a thin-walled structure, right? It's not as beefy as the left ventricle. Okay, and then tension pneumothorax. We mentioned tension pneumothorax already, right? This is where you are pushing all this air into the chest, and you cannot get that air is not leaving, right? It's staying there, staying behind, and it's creating like a tamponade situation. It's literally pushing on the heart, pushing all of our structures from one side to the other, increasing intrathoracic pressures, and that can lead to my obstructive shock. And what do I get with obstructive shock? If I have a lack of forward flow, right? All that blood has to go somewhere, and it's going to start backing up, and it's going to raise my CVP, right? Raise my PA pressures, especially if it's, if it's a tamponade situation. We can say if it's just a PE, it's not going to raise my PA pressure, my wedge pressure, right? And peripheral edema, especially if I can't pump the blood forward, right? The left ventricle, like a tamponade situation, it's all going to back up in the lungs, right? And then the S&S fires off. I get tachycardia, so I'm not getting blood pressure out here in the aorta. So I'm going to start increasing S&S activity, right? I'm going to start raising the blood pressure any way I can, right? It's going to trigger off the RAS, it's going to trigger off the S&S, it's going to trigger off vasopressin. All these hormones are going to get released to try to raise the blood pressure, right? Is that going to help out the heart that's barely able to squeeze anyways? It's very arguable, but definitely we're going to start getting definitely get cold skin. We're going to get that tachycardia, right? You always have tachycardia with shocks, except for which shock? neurogenic shock, because neurogenic shock by definition is a lack of SNS activity, right? So you always get tachycardia, you always get this SNS response, this vasoconstriction, and this cool, clammy skin, right? 'Cause that's all SNS. But why do I get like warm skin, right, with early sepsis, right? Why does my blood pressure go up with SNS activity with like a distributive shock? Because there's something else in the way, right? Either it's histamine and anaphylaxis, it is lack of SNS and neurogenic, or it's the inflammatory mediators in septic shock that are stopping the ability of my SNS to do its thing, to vasoconstrict. Okay, and since I have this profound drop in blood pressure, my kidneys are going to start getting upset, right? And I can measure that in labs with the BUN and creatinine. And I get what's called ATN, which is acute tubular necrosis. We'll talk about this more in renal, but that's just a fancy way of saying MI of the kidneys, right? So the kidneys are not getting flow, they're not getting oxygen, so they're going to start dying off, right? And they might recover, but they might not recover. And we can trend that with the creatinine, okay? And of course, the heart's going to start getting affected, start leading to MI, and now you're down into cardiogenic shock territory, right? So obstructive shock can put a lot of stress on the heart, and that's kind of why there's some overlap between it and cardiogenic. All right, so what are our causes of shocks? So first we'll talk about distributive shock, also known as vasodilatory shock. And again, it's an umbrella term, right, for 3 shock types. What are the 3 shock types it's under? Septic, right? You got septic, neurogenic, and anaphylactic shock, right? And there's some other ones out there, like you can also think of as another, like a little a, is like an Addison crisis, right? They're not getting their steroids, right? Steroids are what prime the SNS to work in the first place. So if we don't have we have long-term steroid user, that can lead, and they take away the steroids, now you have a risk for low blood pressure, okay? So septic shock, right? That's our most common, right? That's about 64% or 62% of our shocks is a septic shock patient, right? So that's why it's important to recognize these patients, right? And why does it happen? Yes, there's lactate building up. You can think lactic acid coming up, but that lactic acid could go up in every single shock. How is that different from septic shock? It's not really. What's really key to septic shock is this increase in our inflammatory mediators. So cytokines get out of control. The complement system gets out of control. The inflammatory response in the body gets out of control. And we try to calm it down with our anti-inflammatory mediators, such as steroids. And we're going to try to calm it down, but there's an imbalance happening. There's too much inflammation occurring. And we know when you get inflammation, when you stub your big toe, what happens? You vasodilate, right? So all the fluid gets leaky. How leaky? About 95% leaky, right? So all that fluid will then leak into the big toe, and then it gets redness, right? Because it gets erythema because of the local inflammation. It gets warm to the touch, which is why early sepsis has the warm to the touch feeling, right? And then we get the infiltration of, WBCs. WBCs are going to get activated, especially if you lacerate your toe. Now they're really going to go haywire. Your WBCs are really going to go up. The toe starts getting infected. It's going to get really red and nasty, right? And angry, I should say. So that's all a septic process in my toe, right? But now imagine it's everywhere in the bloodstream. Everywhere in the bloodstream is now vasodilated and leaky, and white blood cells are everywhere, right? And the inflammatory response is everywhere. So I got this fever response, and I have the SNS firing off, right? And all those inflammatory mediators are going to start making me confused, especially if I'm elderly. And all those inflammatory mediators come from somewhere, right? Your body's going haywire for a reason. And septic shock is because of an infection. And SIRS, or systemic inflammatory response syndrome, it's because of something else that's not infectious, but they're identical. The only difference between SIRS and sepsis is one has an infectious source, one doesn't, or we haven't found it yet, right? So pancreatitis is not a bacterial infection, right? A burn is not a bacterial infection. Like, you don't come out of a house fire, oh, you got an infection. No, they have a surge response because their body was put under a huge amount of trauma. The body's going to over-respond, right? So when someone has a scorpion bite, they're going to over-respond, right? When they have a trauma, like a motor vehicle accident, they're going to have this widespread surge response. When their heart stops and people are doing CPR for 15 minutes on them, that's going to cause a widespread surge response, right? It wasn't because, yes, it could be an infection that made them collapse and arrest in the first place, but if they have this cardiac arrest, that's going to be a surge response in of itself, right? So post-MI, usually like post-CABG patients, when they go to be put on bypass, when they take them off bypass, they have this surge-like response, right? They get the confusion, the vasodilation, cardiac stunning, and all these things that would be expected with a surge response. It's just a systemic inflammation, right? And inflammation is just our complement system and our inflammatory mediators, tumor necrosis factor alpha and interleukin 1, 6, 8, all the different inflammatory mediators are going haywire. And our body's going to try to stop it, and we can help our body by giving it steroids, right? Because steroids are anti-inflammatory, right? They're going to stop the white blood cells from migrating in the tissues. They're going to stop this inflammation at its source, right? Anaphylaxis, kind of similar vein, but anaphylaxis is due to histamine. It's not due to an inflammatory response. Yes, histamine is an inflammatory response, but it's just primarily histamine that's getting out of control. And histamine is the opposite of what other natural hormone that we have in our body. It has the exact opposite function as the SNS hormone known as epinephrine, right? So epinephrine is going to bronchodilate, it's going to vasoconstrict. Whereas histamine does what? It vasodilates, and it bronchoconstricts, right? So histamine is going to definitely, so when it's anaphylaxis, they can start getting wheezy, they can't breathe good, right? They can develop hives, which is a unique feature of histamine. And the histamine is spreading throughout the body, and that's going to definitely cause a widespread vasodilation. Okay, so anaphylaxis will cause vasodilation, a systemic widespread histamine response. And then adrenal crisis. So adrenal crisis is, again, where someone did not resume their home meds. So that's why doing home med recs are so important, because you got to capture things that shouldn't be just let loose for until someone notices, right? We have to notice that, hey, they were on steroids at home. Hey, they're in shock right now. What kind of shock are they in? They're in a distributive shock, right? Because their steroids are what kind of primes the SNS, right? Our SNS is what vasoconstricts and has to go to the vasculature and vasoconstrict. If there's no steroids present, it's not going to vasoconstrict good. So we want to make sure that we have those steroids there, right? So our body's on a use it or lose it system. So if you are not producing your own steroids, or you can't produce your own steroids, or you're getting steroids from outside, it's like, hey, fine. I mean, you know what? You can have them. They're yours. Are those your steroids? And you take those steroids, and your body just shuts down its steroid production. So now you have no steroids once they stop taking once you stop their outside steroid use, right? So lack of endogenous steroids. Endogenous being the steroids that we produce, inside, right? And then neurogenic shocks. So we have a lack of SNS activity altogether, right? So in the steroid situation, we have SNS activity, it's just they can't respond to the vasculature because the vasculature is not primed to steroids. Same thing, thyroid hormone is what's responsible for priming or for making norepinephrine receptors and alpha-1 receptors on our vasculature and primes them as well, gets them ready to receive an SNS response. So someone who's super hypothyroid and who doesn't get the thyroid medication in the home med rec can then develop a hypotension because of it, right? But neurogenic shock, the difference is that they are not getting any kind of SNS activity, right? Specifically, usually around it could be any level, but when we start getting high up around T5, that's where we're going to start getting a bradycardia, because we know that SNS activity causes tachycardia in every single shock, except for neurogenic shock, right? And in neurogenic shock, you can get a bradycardia. It's not always, but you get bradycardia as a neurogenic shock when it's at a level of T5 or higher, right? But if it's like T7, am I going to get neurogenic shock? Yeah, you can still get neurogenic shock because everything below the level of T7 is vasodilated, right? So everything's vasodilated. So that means there could be an increase in CPP or a decrease in CPP. It's a decrease in CPP. CPP is a measure of the right atrium pressures. And if I have all this fluid leaking out to the periphery and none of it returns back to my heart, right? And distributed shock up here, right? All this blood is all pooling now in the extremities, and very few comes back to the right atrium. Very little blood come back to the right atrium, right? The SNS is going to try to squeeze down, but in neurogenic shock, it's broken, right? There's no SNS activity to squeeze, right? You're sending signals down from the brain, but it's going to stop at whatever level they have a spinal cord injury. Or if they have a brain insult, a traumatic brain injury, or herniation syndrome, In the brain, obviously, you're going to be herniated onto the medulla, which controls your SNS, right? So any kind of medullary damage can cause a neurogenic shock. Okay, so a C-spine injury, right? C-spine, C3, 4, 5, C7. These things are going to, that's above T7, right? So I'm definitely going to have a neurogenic shock. But will I have a heart rate change or no? You will, because why would you have a low heart rate with a C7 injury? Yeah, because it's above T5, right? So the signal has to be, it's created in the medulla, and it's going to not be able to reach the heart, right? And then liver failure. Liver failure can cause a vasodilatory shock. So we have a patient that has a lack of albumin, right? Yeah, that can do it. That could cause, that's kind of like hypovolemic really, but really it's this leakage of splanchnic vasodilators. As we'll learn in cirrhosis patients, right? They have this portal hypertension. They got all this really, really high blood pressure in their belly and their GI system. It says, I know how to fix it. I'm going to create vasodilators to vasodilate my vasculature in my belly itself. And then little they know, then that's going to dilate and it's going to fill up with fluid and make the portal hypertension worse. It's like, oh, that didn't work. But then those dilators actually leak across through the liver into the normal circulation. And now you have this widespread vasodilation in the system, not only the portal circulation, but also the systemic circulation. Right? And distributed shock can also be due to excessive vasodilatory drugs. Right? So someone took too many of their what? What's a vasodilatory drug? Sildenafil. Okay, they took sildenafil with their Viagra. That could do it. All right, what else? They took too much nitroglycerin with their sildenafil. What else? Steroids? No, steroids will actually raise your blood pressure, if anything. Lack of steroids, and now we're back up to adrenal crisis. But so I said iatrogenic, so it means that's something that we caused it, right? Their blood pressure was 90 systolic in the morning, and we gave the Coreg, we gave the carvedilol, right? That is a vasodilatory process. Or grandma forgot that she took her beta blocker in the morning, and she took her couch, and then she took it again at lunchtime, right? That is a vasodilation process. Is it a septic process? No, it's a vasodilatory process, right? So too many vasodilatory drugs. Liver failure mentioned, adrenal insufficiency mentioned, all these things, the common denominator is vasodilation. But what's the most common reason for vasodilation? Is our sepsis, right? Or septic processes. And these are all going to cause, obviously, a low blood pressure. Are they all going to cause tachycardia? All except for neurogenic shock. Everything else will cause tachycardia, right? So everything will come down to tachycardia because you have a decreased return of blood to the heart, and now the heart can't pump that blood forward. It pumps less blood out into the system, and therefore your SNS is going to be keeping track of those baroreceptors on the aorta and say, hey, why is there less pressure in my system right here? Let's vasoconstrict as much as I can. And it's going to try to vasoconstrict, but it could be interfered because of inflammatory mediators. It could be interfered upon because there's neurogenic shock. It could be interfered upon because there's no steroids or thyroid hormone. It could be interfered upon because someone took too many of their calcium blockers, or too much of their hydralazine, or too much of their clonidine, right? So that's the idea behind vasodilatory shock, right? With the SNS working, you're going to vasoconstrict. If it doesn't work, right, it's going to vasodilate, right? It could be due to inflammation, or it might not be due to inflammation. It might be due to just a neurogenic process, or again, they overdosed on their hypertensive meds. Okay, so looking at the different shocks, again, we're over here on distributive shock, sepsis, burns, anaphylaxis, neurogenic reasons, right? Trauma and surgery can lead to a surge response as well. But also trauma and surgery can lead to hypovolemic shock if we're losing what? We're losing blood, right? And we kind of talked about obstructive shock already, but the idea here is to kind of say which kind of shock it is, and we're going to do diagnostic tests to figure it out.